morning, Lebanon. Good morning, Morocco. It's a great pleasure to be here with you. Thank you. Thank you, everyone who's coming to this lecture, the Pan-Arab. I would like to present Dr. Ahmad Rassani Al-Adib from Morocco. He's a professor of anesthesia and critical care. He's the head of the Department of Anesthesia and Critical Care in Gynecology and Obstetric at the Mother and Child Hospital, Muhammad VI University Hospital. He is the educational manager of Marrakesh Simulation and Innovation in Health Sciences Center, the CSI2S, Faculty of Medicine, Qadi Ayyad University, Marrakesh, Morocco. He is also the immediate past president of the Moroccan Society of Anesthesiology and Intensive Care. He's the vice president of the Moroccan Society of Medical Simulation and the African Regional Section of the WFSA board member. Thank you, Ahmad, thank you, Dr. Adib, for coming. His topic today is about the safety in obstetric anesthesia. Dr. Adib, the screen is yours.
Thank you very much, and thank you to PAFSA for the invitation. Thank you for the kind presentation. And also, I'm very happy to be with friends and with experts. So the topic is very large. So I have chosen some topics which are much more important for me, and I will give a little bit a big view about that. So I don't have any disclosure about the topic, and I will start with the statistics. I choose two studies. The first one is African Surgical Outcome Study published in 2019, which was held in many African countries. It's more thousands of patients and thousands of obstetric situations, and the result was scaring because maternal mortality after cesarean section in Africa was 50 times higher than that in high-income countries. And two causes, major causes, were peripartum hemorrhage and anesthesia complications. Also, neonatal mortality was double the world average. And that's important for us, and it's an important basis. The second study is a study that was published in 2001 by the French Committee of Auditing Maternal Mortality, and it was focused on obstetrical hemorrhage in three regions, and the independent factors associated with maternal mortality due to hemorrhage were two. One is the activity of maternity, less than 500 delivery per year, and another one, very important, with up to 3 times risk is the absence of anesthesiologists 24 hours a day. And you know, in our country is the problem with human resources, especially in anesthesia. And in discussion, they said that the important role of the anesthetist may be related to these two independent factors. Firstly, because postpartum hemorrhage are generally unforeseen events, and we have statistics that the 2/3 of obstetric hemorrhage are unforeseen season. We can detect them before. And the second is because anesthesiologists assist at a high percentage of deliveries through local or regional anesthesia. Okay, I'm sorry for this connection problem, independent of me. So I said that in cesarean delivery, 50 times higher risk of maternal mortality because of peripartum hemorrhage and anesthesia complications. And in the French study, the absence of anesthetist is independent factor for this mortality, especially because safety issues. And the lessons that public health planners should learn from these results, the important role of the anesthesists in delivery and safety points, and the necessity to ensure a sufficient number of these specialists, particularly with this specific training for obstetric care and their presence at all levels. So human resources problem is important for safety issues. There was a research recent research in 2018 about the impact of obstetric anesthesia on maternal and neonatal outcomes, and by classing subject areas of obstetric anesthesiology research, they classed that the importance of each topic, labor analgesia, come in the first each topics that have an important impact on maternal outcomes. It's important also because there are unexpected events, obstetric maneuvers, instrumental, artificial, true to cesarean delivery. And I'm responsible of maternity with 16,000 delivery per year and more than 8,000 intervention anesthetic procedure. And I believe that the most important thing that changed safety in epidural analgesia was to change to low concentration, high volume. 8 years ago, we moved to using a concentration of 0.06 to 5 bupivacaine, and after safety has enhanced very, very well, and also the quality for epidural analgesia and obstetric. Epidural avoids general anesthesia because in this study about this numbers about maternal mortality, anesthesia is responsible for 3 to 12% of all maternity deaths, and majority during general anesthesia in emergency setting. And we have 3 components for this anesthetic mortality: is general anesthesia in emergency C-section with airway problems. So one of the most important indications in cesarean delivery is rhythm disturbance. So we have to take time. We have to do the concept of in utero fetal resuscitation. Very, very important. We have to take time to do local regional anesthesia in a safe way. Gunpanaver said, better fetal and I add and maternal outcome doesn't depend on how fast the baby is delivered, but on how well the mom and the baby is delivered, and it's physiologically comprehensive. There are another issue with preeclamptic perturbiance, for example, because we have many accidents for airway, and we have also strokes because we are fast, we don't use some things. So for difficult intubation, we have to be prepared, and we have to collaborate with our first collaborators, anesthesia providers that are very skilled in airway skill, and also avoid hypertensive response to laryngoscopy. We have to move to some new technology in crisis situations, especially in hypovolemia or maternal cardiac arrest, to have a very fast vascular access. Monitoring also is very important. There is by a side the development of ultrasonography for monitoring and diagnosis, and also the development for non-invasive monitoring, hemodynamic monitoring, because most of the crises in obstetric anesthesia are very fast, unforeseen for some, and we need just maximum 1 hour to do everything. We don't need to go very, very high monitoring in most of cases. Ultrasound, I talk about that for everything, for monitoring, for diagnosis, and also for local regional anesthesia. And in the future, that the ultrasonography will be the stethoscope for every clinician, not only anesthesiologists. Enhanced recovery after surgery, there was a great topic from Alison, so I don't come back to this. Of course, in cesarean delivery, there is no efficacy demonstrated in data, but it demonstrated everywhere. And if we compare with settings that don't have many standards, outcomes are very important in this topic. I believe that enhanced recovery in obstetrics is a very great value for safety. And there is a very new publication this month about specificity of patient safety in obstetric anesthesia, about the possibilities to improve patient safety. Continued topics are very important: continuous education, teamwork, communication, best practice protocols, safety checklists, and simulation training. All that can be done with simulation training, and also medication errors, labeling, preparation, and many topics inside. For example, there is this SBAR concept is a communication tool that is very important in communication between professionals for every situation, but especially in obstetric anesthesia when handover. So we can train our collaborators to use SBAR concept for communication to enhance the safety. Also, we have to use checklists. At least the minimum is the WHO surgical safety checklist with multi-professionals, all the team around the cesarean delivery. We have to do also protocols, specific protocols, but personally, I love checklist protocols. For every crisis, we take a checklist and we check the algorithm we have to do. For example, here in the Moroccan Society, we use a checklist for difficult intubation. We did with the Gynecologic Society for postpartum hemorrhage. We use also the eclampsia checklist by the French Society. So there are many possibilities in this way. And for implementing all this communication, checklist, protocols, we have to train teams. Simulation in obstetric anesthesia has proved that it enhances technical skills. It can evaluate clinical performance. It helps assess the safety of the environment of care and improve teamwork. There was a publication in 2015 about advances in obstetric anesthesia in simulation. So they said that simulation to teach individuals technical skills and individual behaviors in obstetric is effective with likelihood of long-term retention. Certain low-fidelity simulators are effective tools to teach practical neuraxial procedures and other procedures, and in situ and off-site team simulation may have similar effectiveness in teaching obstetric anesthesia. However, organizational factors that impact team performance may be more done in simulation and conducted inside. And a simple example, we have many studies about the interval decision of cesarean incision, and we can do training about this. So there are many examples of task trainers, low fidelity, standardized by patients for communication aspects, and also we can do hybrid simulation for crisis management, for epidural, for labor pain, and also we can use virtual technology for many things, especially ultrasonography. And for cognitive aspects, serious games are very valuable, very important to permit retention of protocols and algorithms for the whole team. Now, for installing a culture of safety, we have to know that there is many barriers, many defenses. And if we have rupture in defenses, we can have accidents and we have poor outcomes and we have safety issues. And we can, every one of us has individual role to play, but the team and the managers have to play roles, because if we have holes in the barriers, the problem is there will be too much reliance placed on frontline staff, especially anesthesia providers. So we have at a local level to install bundles, for example, here bundles for obstetric hemorrhage, for thromboembolism, bundles about readiness, recognition and prevention, response, and reporting system and learning. Reporting systems are very important. Debriefing of crisis, staff for reporting morbidity, and a culture of empowerment and avoid safety issues. For that, at international level, there is the Helsinki Declaration of Patient Safety in Anesthesiology, with very important topics which obstetric anesthesia is concerned, about checks, syringe labeling, anaphylaxis, protocols, and many other issues, very important. And we believe that if we sign, for example, this declaration, we can put pressure under our governments to enhance and to improve the situation. For example, I did it for my society in 2015. And we have national protocols also, guidelines. We have national guidelines in Morocco, and we participated with I am still a member of the Safety and Quality of Practice Committee of PAFSA, and we did guidelines for safety. In Morocco, we did specific guidelines for obstetric anesthesia. And we have international standards, and we had in 2 years ago, publication by WFSA and WHO for the international standards of safe practice of anesthesia. And there is levels, human resources, what we have to do for each. I think it's very important for governments to adopt these standards. We have an occasion, very important occasion, next 17 September 2021, with the Patient Safety Day. And the topic this year is Act Now for Safe and Respectful Childbirth with Safe Maternal and Newborn Care. And we have, the objectives are very important to raise global awareness, to engage multiple stakeholders, and call for urgent and sustainable actions to enhance safety in obstetrics. And we anesthesiologists, we play a key role in this. So my conclusion, I hope I gain time. Obstetric anesthesia has evolved over the course of its history to encompass comprehensive aspects of maternal care, ranging from labor analgesia and cesarean delivery anesthesia to maternal resuscitation and patient safety. Anesthesiologists play a key role with maternal and neonatal outcomes, and with preventing and managing complications that may present during and after childbirth. Future progress in safety field will continue to have significant implications on the health of women and children. And we are anesthesiologists, we are facilitators, and safety is our first mission. But there is a condition, it's our well-being. Thank you very much for your listening.
Thank you, Dr. Allison, for this excellent and informative lecture. I have one question, actually two questions. What are the difficulties that you have encountered to apply all the elements of the ERAS for cesarean section? Because as you presented, the list is quite long and exhaustive. So what really the difficulties when you apply the ERAS protocol at your institution? And the second one, in countries with limited resources, what are the most important elements in the application of the ERAS for cesarean section, of course?
Thank you for the questions. I think one of the difficulties with the ERAS protocols is that it requires interdisciplinary cooperation. So we're not talking only about anesthesiologists. And so there are a lot of aspects that we don't actually have any control over. So I think I would say that would be the biggest challenge in terms of getting the buy-in from all services and requiring that cooperation. With respect to your second question was the challenges.
In countries with limited resources, what are the most important elements to apply the ERAS for cesarean?
I think every country will be somewhat different. I think being able to sort of optimize maternal health leading up to the time of delivery is going to be key. But I think I realize that also in terms of anesthesiologists, it's hard to affect change at that kind of level. So I think that's one of the bigger challenges. But I think what can be actionable within an institution can be sort of preparation and readiness for events. And you can affect, for example, how quickly you try to mobilize women, creating a culture where you're promoting breastfeeding and so on. That's what's the stuff that you can do within the institution.
Okay, thank you. Okay, I'm done with the question with Dr. Allison.
For Dr. Sami, we have a question about most of cesareans are performed under general anesthesia. As obstetricians are comfortable in performing these, are there any advantages by performing under spinal anesthesia and any evidence?
I wonder if this question for Dr. Adib or for me, because my lecture was about sepsis. So probably Dr. Adib would rather answer this question.
I think so.
Is it okay?
But you are an expert also, Sami.
Okay. Okay. Now the question is there any advantage for general anesthesia and obstetrics? Actually, there was a time when authors and investigators have tried to rock the boat again to find a place for general anesthesia in obstetric in cesarean section delivery. And obviously we have to admit that we have to be able to conduct general anesthesia safely, because in some circumstances we cannot afford giving regional anesthesia, and this is actually not uncommon to see in our daily practice in patients with thrombocytopenia, those who have some like anatomical difficulties or crash cesarean section where obstetricians cannot afford waiting for a spinal anesthesia. Though in my institution we do this as fast as conducting general anesthesia, but however we have to do this very efficiently, and I, from my perspective, have to say that general anesthesia still has a role in those cases, but the problem is to make our staff and anesthesiologists be able to conduct this safely. And one of the things actually that I've come across in the UK, and I found it very reasonable, that in each and every general anesthesia case, another senior anesthesiologist come to join the anesthesiologist, the anesthesiologist conducting the anesthesia, and we've actually implemented this in my institution. So every time there's a general anesthesia in cesarean section, they call the other anesthesiologists to come and be standby, and this actually helps a lot in preventing any problems in case of difficulty, because I mean certainly the anesthesiologist will behave far better than a technician, regardless how skilled the anesthetic technician is. And also our technicians are very much used to preparing all the gadgets in case there is anesthesia difficulty in intubating those patients, and also they know by heart all the algorithms that can be used for difficulty intubation. However, probably and also one of the things that I need to stress upon, if we have to give or general anesthesia for patients with preeclampsia, we have to make our effort to reduce the blood pressure to a bit of safer limits before trying to do this, because the consequences are really tragic. And again, as Dr. Adib said, mom takes the priority over the baby. So we have to reduce the blood pressure down to below 150/90, probably at that range of blood pressure, in order to avoid the high surge of blood pressure in response to laryngoscopy and intubation, using all other means to calm this stress response. Thank you.
I wouldn't say better.
Thank you so much.
Okay, first I have one message from the organizer and organizing committee that we will resume after 3 p.m. Beirut time. I have a questions for Dr. Adib. Two questions actually. The first one is about COVID-19. Did COVID
monitoring in ORs, and we are introducing also high nasal oxygen in our recovery suite. Now about simulation. Since 2012, we have more and more studies that are showing an impact to the outcomes through simulation training. I think obstetrics and cesarean delivery is the same thing that a plane cockpit crisis resource. It's the example, the type example in risk, in management that is like aviation. So we know now that aviation has improved, especially and centrally with simulation. And I think in the future, simulation will be a main tool of training, even in pre-graduate and in continuous education. And we have to we don't need to forget that it's a tool. It's a technique. It's a pedagogic approach. It's not the solution. It's not technology. It's not mannequins. It's the approach. It's the pedagogical approach. Simulation is a tool that can have to be done in a program, in a curriculum, which includes other tools.
Yeah. May I add something? In our institution, in Cairo University, and we have a STEM lab, and it's the only one in Egypt till now. Before having COVID-19, the simulation courses were part of the logbook, so it's mandatory. We give simulation courses for all our candidates, starting from the registrar at the first year. So we have basic simulation courses and advanced simulation, and the feedback was actually great. And we have invited the Royal College of Obstetric and Gynecology together with the Anesthesia department, and we had MOIT, Management of Obstetric Emergency and Trauma course. It's for the first time this course was given outside UK. It was in 2019, and we had the founder of the course and the instructor, and they give a mini course. We use simulation for the difficult airway, for CPR during maternal collapse, neonatal resuscitation, and all these courses were given using simulation. And actually, for both obstetrician and anesthetist, it was a very good course. And the feedback from the candidate, we usually take the feedback, and they said it was very rare, and they had a very good experience.
Thank you. Thank you, everyone. Hope to see you next time in person. Be safe.
Thank you so much.
And have a great afternoon.
Thank you,
Thank you. Thank you, everyone.
Thank you.
Have a nice day. Thanks a lot.
You too.
Cheers. Bye-bye. Thank
Bye.
you.
Bye-bye.